Let's see what Dr. BIBHUTI has to say about perimetry. Now it's time to introduce the chief instructor, Dr. BIBHUTI Prasanna Sinha, Professor BIBHUTI Prasanna Sinha. He is the chief of the RIO Patna and one of the best speaker we have in our Bihar, one of the very good administrator and very knowledgeable person. So welcome, Dr. BIBHUTI.
Sir, regarding your last question, when visual field estimation is not possible, there should be a clinical correlation between your OCT finding and your disc finding. Then only one should start with the treatment. So I'll be talking on interpretation of automated perimetry. Because of paucity of time, I'll be skipping with a few slides. So these are the utilities: glaucoma, neurological disorders, retinal disease, visual disability. Out of these four, the glaucoma, neurological disorders, and the visual disability are the main armamentarium which are being utilized for perimetry. The automated perimetry is one which is used nowadays because of a standardized way, accurate and reproducible results, and because of the less variability. We know the static perimetry is more important since it determines the retinal sensitivity in the visual field at different foci. We also know that the fovea has got the highest sensitivity, that is around 30 to 34 decibel. That means it can detect the dimmest possible light. The threshold is one terminology which means that the stimulus should be picked up at least 50% of the time, then it is termed as a threshold value. The decibel is the retinal sensitivity, whereas apostolib is basically the light intensity. The thresholding is usually done by two strategies, by 4 to dB decibel double bracketing strategies, where the intensity of light is decreased by 4 decibels and increased by 2 decibels in a step ladder pattern, and to identify the threshold value. And fastpack is where we reduce it by twice by 3 decibels to identify the threshold value. Now, the threshold value of 1 point can be determined or can be rely upon because of the size of the intensity, size of the stimulus, that is usually type 3, the 3 luminous intensity, the background illumination, which is around 31.5, which was also present in Goldman as well as Humphrey, or in the octopus, the color and the duration of the light presented to the patient. Then there are age factors, size of the pupil, refractive status of the eye, attention of the patient, and fluctuation. These are important factors that can determine the thresholding. There are various ways, qualitative and quantitative. Qualitative means supra-thresholding. That means you are presenting to the patient a age match control value which is more than the threshold value of that age match, and that identifies basically is a used usually for the neurological field, and it's a kind of a screening test. Whereas the quantitative, we actually identify the threshold value at different focus. These are some of the test pattern, that is 30-2, 24-2, 10-2, and now these are the test locations. In 30-2 usually we do 76 point testing, in 24-2 we do 54 point testing, and 10-2 we do 68 point, because the macular ganglion cells are the maximum represented at the cortical level. Now the newer pattern, that is 24-2, where 10 added points in asymmetrical pattern has been added into 24-2 program, and which gives added information about the central changes occurring to the patient. Now coming to the parts of Humphrey, this is the printout. So for convenience, I personally bifurcate it into 4 parts. Part A, B, C, and D. So see, part A has got all the information regarding the patient and the reliability indexes. Type B part has got the actual threshold value and the grayscale type. The part C has got the total deviation and the pattern deviation plot, and the part T is the statistical analysis of the printout. So let's go one by one. The part 1, the stimulus size will be there, background will be there, the test strategy has to be seen, the refractive status has to be seen, and then the reliability index. Please make sure that your macular foveal threshold matches with your visual acuity of the patient. Coming to the reliability index, there are false loss, false fixation loss, false positive, and false negative. The fixation loss is once the patient, if the patient is detecting the stimulus presented at the blind spot. The false, if it is more than 20%, the flag is on. The positive, false positive means the patient has presented or pressed the buzzer even at the sound or before the light is presented to the patient. If it is more than 15%, the test is flagged off as an unreliable play test. Then the false negative is when the patient has estimated number of the time expressed as a percentage, the response button is not pressed when the stimulus 9 decibel brighter is presented to the patient. And if it is more than 20%, then again it is flagged. If there is high false positive, there will be white scotoma. If there is high false negative, the patient with pattern will present with a clover leaf pattern, and these are two specific type of pattern which need to be identified before you get into the further details of the patient data. Now, foveal sensitivity is very important. In individual sensitivity has to be seen. Then gray scale has to be seen. The total deviation and the pattern deviation. The total deviation is regarding the average deviation from the normal age, normal threshold value, and the pattern deviation is when you flatten the curve, you take out the general depression in the curve and then point out where the foci of the depressions are there. So this pattern deviation is of more important than the total deviation. Then coming to the mean deviation and the pattern deviation, mean deviation is basically derived from the total deviation plot and indicate overall depression of the patient hill of the vision. So even with a cataract, even with all other media opacities, the mean deviation is going to go down. In case of PSD is also derived from the total deviation, but it actually denotes what is happening at a particular focus, and that tells how the numbers are different from each other. So it is more specific for the test. SF and the CPSD are now not available in newer machines. Then the glaucoma hemifield, it will flag you, it tests 5 points in the upper field and the 5 points similar symmetrical fields in the lower field, and then it gives you information in term of outside normal limit, borderline, abnormally low sensitivity and abnormally high sensitivity, which will give you information whether there is asymmetry present or not. You know that the glaucoma damage is asymmetrical. So, and then the gaze stacking, remember the upper movements of upper spikes are basically of saccades and the lower spikes are basically of blinks. If there is jumbling of these blinks or the saccades, that means the patient reliability is poor on the gaze stacking, and that need to be taken care of in the further field evaluation. Now the criteria of diagnosis: 3 non-edge point present depressed to more than 5% and at least 1 point by less than 0.5%, 1% in the cluster area, PSD depressed by 5% and GST outside normal limits. So one has to remember whether the field is asymmetrical or not, whether the cluster of the defects are present outside the border. So the peripheral areas have to be discarded in cases of 30-2, but in 24-2 one can consider that. Then one has to remember whether the defect is progressing or not, and the progression is what? Progression means whether the progression is in the size, whether the progression is in the depth. So there are various pattern. One is basically when you do a glaucoma overview program, if you have multiple tests, just place it before yourself and see what is happening to the total deviation and the pattern deviation plot. It is going to give you information, or GPA or VFI is going to give you information, but that requires multiple tests on same machine. Then only the machine can basically detect what is happening to the patient visual field. And also the VFI plot gives you information about and comparison with a normal age match control and give you information. It also flags off and give you information in form of single solid dot that indicates point not changing a significant amount, a small open triangle that means the test is expected to be present in stable glaucoma patient, p value is less than 0.05%. A half filled triangle means half filled triangle is indicates significant deterioration at that point in 2 consecutive tests, and a solid triangle means in 3 consecutive tests. That means that this is pathological and the patient is progressing. So at the end, I want to say that Humphrey field analysis or the perimetry is one of the mainstay of evaluation in case not only of glaucoma but also in cases of neurological field. And for the disability purposes, or continuous and a repetitive examination is required to first to get a reliable visual field initially, and then repeated tests are required to identify actually what is happening at the micro level. Thank you very much for your patient hearing.
For neurological, what are the subtle early changes which can be useful in
I think
perimetry?
there is one criteria, RP Mills criteria is there, where one has to see the vertical line. We know that the glaucoma respects the horizontal meridian, whereas neurological fields respects the vertical meridian. So you need to compare 2 or 3 the corresponding points on each side of the line, and whether there is change in the luminosity, whether the intensity or sensitivity of those 2 points. And then the next step is to find out what has happened to the next one line into that. And if there is definitive change and there is asymmetry, it goes more in favor of a neurological field. So that is more important. And more so, one should go for 120-degree rather than 30-2. It is a kind of a screening program, give you a good kind of information in neurological fields.
There are some new machines we have seen in the, somebody purchasing a small that can be used as a spectacle kind of thing. So do you have any idea how these machines are comparing with the standard perimetry machines?
There are few papers which are giving information that the comparison is good, but personally I have not used these machines. Basically give you informations. They are very patient friendly. One, they can be utilized even in the OPD. They don't require a lot of space or the dark room to actually perform. And personally, I think that that can be utilized for screening purpose rather than for the diagnostic purpose or for assessing the actual progression. So before you move to diagnose patient, if we have to do the screening of patient in a busy OPD, these machines should be utilized or could be utilized. But once the patient has been diagnosed as a case of glaucoma, the perimetry should be performed on the gold standard, that is Humphrey field analysis, and so that actual findings are perceived, and then the field estimation can further be done to assess the progression in future.
For any patient who are suspicious of glaucoma, how many field you think should be taken before completing coming to the conclusion that this field is reliable? Now we can follow.
Basically, sometimes even the patient, those who are intelligent patient, they can perform even in the first test itself. But usually 2 to 3 tests are required, and the reliability parameter is one important thing what one should keep in mind. If the reliability parameter is good and the patient test is absolutely normal, then this patient can be followed up later on for like if the patient is termed as a glaucoma suspect because of the disc changes, and that's why the patient has been taken, but the visual field turned out to be a very normal with a good reliability, this patient can easily be called after 6 months for repeat test. But you have to keep on performing these tests at least 4 to 5 times in first 2 years to see what is happening at the micro level. So this is how I personally move. If the patient test is not very reliable, then naturally we have to perform these tests at least 2 or 3 times to take out a good printout. And more so, when we are also seeing the progression after treatment. Once you have done some kind of surgery, then you have to create another baseline to see what is happening further into the patient treatment protocol.
So the baseline perimetry keeps on changing depending upon the stage
Exactly.
of the disease.
Exactly.
So any other question from the audience? Yeah.
MRF tablet-based perimetry in our department, and that was basically used in the COVID times when you didn't want to put the patient in a dome chim perimeter. So that's iPad-based, and it's fast. It doesn't pick up the early fields, but it doesn't miss out, in the moderate fields, and it collaborates with the automated perimetry that we have. So
Exactly. These are the tests which can be used for screening as a screening tool in the OPD, where because in glaucoma, we require some kind of tool which can screen masses. At the end of the day, you can't perform Humphrey in all the patient or octopus in all the patients. So you require a test which is fast, which can at least detect some true positive patients. And so there these machines fills the gap.
Above all, what is more important is clinical evaluation of the disc, the nerve fiber layers, and other things. Because many times the field comes out to be not as in the accordance with the clinical finding. So in that situation, one has to repeat the field again and then see that which.
Dr. Mamta is doing one paper on research on one field that is for driving license part.
Yes, sir. We have this latest.
Tell me something about it.
Yes, we have this latest machine by Zeiss which has Esterman component also. Esterman actually is the most widely accepted test for driving license in Western world at least. We do not, right now, we do not have any, criteria when it comes to giving the driving license that we need to go for perimetry. So what we are planning to do, we are taking the patients and we are performing Esterman to the so-called normal license holding Indian population actively involved in driving, and then we are just going ahead with the study. Let us see how and when it happens.
So basically in India we don't require field analysis for driving license,
yeah.
because although that is very important part. So that test is kind of supra threshold test. Okay. So at the end, I want to thank Dr. Sumas.
Thank you so much, Dr. Vibhuti, for such a wonderful talk.